Good morning, everyone, and welcome to the SCAGO Summit 2023. My name is Amos Tunji-Ajayi, the Education Coordinator at SCAGO, and I will be moderating today's session on non-pharmacological management of sickle cell pain and lived experience of non-pharmacological management of sickle cell pain. So if you or members of your network would like to refer back to the information shared in the session, a recording of today's session will be posted on our website for your viewing convenience. So in this session, we will be hearing from two guests who I will introduce. So I will start off with Beatrice Kahenya, who is a nurse practitioner at William Osler Health System Adult Sickle Cell and Thalassemia Program, where she works closely with Dr. Andrew Binding. She originally attended the University of Toronto, where she received a Bachelor of Science degree in nursing. She later pursued the innovative Master of Science in Nurse Practitioner Primary Healthcare specialty at York University in 2011. Over the last 12 years, she has worked as an NP in various care settings, primarily in acute and complex pain management with cancer and palliative care patients. She currently specializes in the care of patients living with sickle cell disease and thalassemia at Brampton Civic Hospital. At BCH, you will spot her at the Sickle Cell Outpatient Clinic, passionately discussing vaso-occlusive pain and complications prevention, disease control, and also you can see her at the emergency department and inpatient wards, managing acute sickle cell pain episodes and associated complications when they unfortunately occur. Beatrice is an active member of several professional organizations and committees, including the Canadian Hemoglobinopathy Association, the Nurse Practitioner Association and Interest Groups of Ontario, and the Black Health Working Group in Osler. In her free time, Beatrice enjoys spending time with her husband and their two teen daughters. She also particularly enjoys gardening and practicing yoga. And now on to Lance Archer. So Lance Archer lives with sickle cell disease and is passionate about improving the quality of life of patients with the disease. He is a member of the board of directors for the Sickle Cell Awareness Group of Ontario and chair of SCAGO's Patient Advisory and Advocacy Council. Lance is a clinical psychology PhD candidate with a research interest in health psychology, specifically treatment adherence. He is currently conducting a study that examines the association between attributional style and adherence to hydroxyurea in adults living with sickle cell disease. Lance aspires to develop psychological interventions to improve the health-related quality of life of persons with chronic illnesses, including sickle cell disease. He enjoys watching movies and TV shows, singing, and eating French fries. So now just on to some of the housekeeping rules. Just before we start the presentation, I just want to let you know that we ask you to respect the learning being done in the space by abiding by the following housekeeping rules. So your microphones have been disabled for the duration of the webinar. If you would like to ask a question, please do so by putting questions in the chat or Q&A function or by raising your hand. We will try our best to answer all questions during today's session. So translation captioning is provided. Attendees can listen to the session in their preferred language by clicking Show Caption at the bottom of their Zoom screen. Check the Enable Translation checkbox and choose the language you want the caption to be translated in. We also ask that you use respectful language in the chat, no profanity or inappropriate images or posts. Please do not post other material unrelated to today's discussion topic. And please keep discussion and comments on topic as much as possible. The SCAGO does reserve the right to pause the session or seek the removal of participants who do not abide by these rules. And thank you for your understanding and agreement to positive participation. And finally, just as a disclaimer, the information shared during the summit does not constitute medical advice. So now that that's all out of the way, if Ms. Beatrice Kahenya can start her presentation, that'd be great.
Yes, thank you, Amos, for that very kind introduction. I will share my screen. No, it's starting. Okay, give me one quick sec. It needs to go to the beginning. There we are. And welcome everyone, and thank you for affording the time on a Saturday to come and learn with us. So we do appreciate that. Thank you for coming. And I have 15 minutes to provide what's most important for this topic on the non-pharmacological management of pain in sickle cell disease. So no conflicts of interest or any disclosures to declare. This is our train ride today, looking at the difference between acute versus chronic pain, looking at where these measures fit in the best and what are the main three modalities that literature and my clinician perspective recommend for this type of management processes. So we do have two types of pain. I think when you look at this, it's very important to see where it's most applicable. We do have the acute sickle cell pain episodes. Of course, we know those are very severe. And as much as we can apply these complementary non-pharm measures, we also want to have this as part of a comprehensive disease management plan. This pain is severe. We will for sure need pain management, usually with something strong, opioids. We'll add on other adjuvants as applicable. We also want to ensure that other ways to prevent controlled pain are in place, such as treatment for sickle cell disease, hydroxyurea, if that's what is indicated for the condition, or other treatment for other complications have also been done. When it comes to chronic pain management, we're looking at pain that's happening on most days for a lengthy period of time, usually for up to about 6 months. With this type of pain, still the comprehensive approach to pain management still applies. We just don't want to say we want to just do the non-pharmacological measures. We might still need some analgesia, some medications as needed. The disease control treatments also are recommended to continue concurrently, or any other complication interventions that may be recommended. I want to make a comment about the interventions for any inherent complications. So in sickle cell disease, I can tell you most of the, for the most part, this pain is mostly from what we call AVN. So this is a continued compromise of blood flow to the joints, usually to the shoulders or to the hip joints. And then with what we call, then you end up with what we call a vascular necrosis. It almost feels the same way as arthritis, or presents much the same way, where the integrity of the joint is compromised. And this is pain ongoing for the most part. If the damage is advanced, you'll have the orthopedic surgeons do a recommendation for surgery, for example. And I do know many of us, of course, would be worried, scared on the risk on complications, especially in sickle cell disease, where maybe transfusions before the surgery may be recommended and things like those. But where it's applicable and it fits with the patient's, what's acceptable to the patient, then really that should also be part of the plan in managing this pain in a more comprehensive manner. All right. And then we want to look at the chronic pains in a more objective version, where we want to make sure we don't over-rely on the use of opioids or polypharmacy in that case. So there are all the research and the guidelines out there, not only actually for sickle cell pain, but for all types of pains, including cancer pain or any other type of chronic pain, where we don't want to over-rely on medications, especially the opioids. It's not recommended that patients continue on taking opioids most days, because we know the risks and the harm is there. So there's something we call hyperalgesia, where instead of having the opioid manage and take away your pain, you instead have more pain. So we see that a lot for patients who are on consistently high dose of opioids on a daily basis or on most days of their life. And when hyperalgesia occurs, now you'll even have more need for more medications to help with the discomfort. So long-term effects might be cognitive changes, where the opioid effect on the CNS system causes some form of cognition impairment, and patients may not be as sharp in their thinking or memory as they were before. So sleep disruption is a common side effect. Other hormonal alterations, we know the bones become fragile, the body easily becomes dependent on these opioids, and then you might even need now higher doses because of the tolerance developed and worsened clinical outcomes. But I have to be careful that, having said that, I do see patients who, even when they are in an acute crisis, just don't want to be on opioids. And then my thing for them is, you don't have to suffer unnecessarily. So if you are under the good guidance by a clinician, that should not be a worry. But as a general rule, we really do not make a recommendation for opioids to be used on a long-term ongoing basis. And that's where really these complementary and farm measures come in to prevent that type of a scenario. So for our talk today, we will look at 3 broad categories of some of these modalities used. I've looked through the literature, and what I'm going to incorporate what the literature recommendations are, and from my clinician perspective. So these are the 3 broad categories we'll be looking at: the cognitive and behavioral strategies, the integrative approaches that require a provider who is skilled and experienced in delivering them, and some of the physical activities and movements that also have been known to alleviate pain and disability. So let's begin with, okay, I just want to comment that even as we look through these modalities, there's not enough research out there that's very affirmative that they work for everybody. Everybody's pain experience is very unique. There's neither, I look at actually the ASH guidelines do not make a recommendation for or against, for example, the physical movement as a modality for pain management, but they do note we do need enough research in form of randomized clinical trials to be able to affirmatively say this really works for sickle cell disease. But in general, this consensus that these are modalities that have been found helpful in a significant number of patients, and therefore they would be worth a trial as we look for more evidence in their applicability. So the provider delivery integrative approaches are things like massage therapy. Those are well known to us. Things like acupuncture, where you have microneedling that are targeted to stimulate the nervous system to possibly trick the nerves on how they interpret and how they relay that pain. The acupuncture actually is known to be effective. There's a common understanding that or finding that acupuncture is helpful during the actual procedure, and the benefits are experienced even after that is done. Then we do have procedures such as transcutaneous low voltage electric nerve stimulation that also work to stimulate the nervous system and to minimize the pain stimuli. For those, for the most part, is mostly during the procedure and not so much afterwards. But when the procedures are frequently done by someone who is skilled, experienced, mostly by physiotherapists or people who have been trained on how to deliver this, the small gains eventually lead to improved outcomes in the pain control. So I'm not an expert in this area because, of course, I'm not a physiotherapist, but I do make a recommendation for my patients to give them a try. The other thing when it comes to me as a provider making this recommendation is to be aware of how I can continue advocating for access, because not everybody has work benefits or access to these specialized experts in delivering these procedures. So that's a recommendation and continued work in progress, especially for our sickle cell population. Then other modalities that really all of us should be doing this, physical activities, movements to improve pain. This might still be the same movements available through a physiotherapist's office, things that we should all be doing every day, walking, doing resistance training, weight bearing, things like doing yoga have been shown to, of course, strengthen the bones, the ligaments, especially like in the case of the AVN, so that the disability is not as pronounced. And with doing physical activity, the benefit is not only in the physical pain and how the physiological effect on how that may be mitigated, but more so even on how this has the benefit on the entire well-being and the mental health of all of us, and for the patients experiencing chronic pain. Okay, I just have to also mention that with exercises such as weight bearing, doing weights or anything like push-ups, those have the extra benefit of building strong bones. In sickle cell disease, we do note a lot of osteoporosis, especially in later stages. One of the things we do encourage is improved bone health through exercise, ensuring that the diet has enough calcium, vitamin D, or doing supplementation if required. So the benefit may not only be in pain management, but then within sickle cell disease, you note that the benefits are over encompassing to also include many other benefits. The other more important modality is the cognitive and behavioral pain management strategy. So there's this concept of understanding that pain is not only physical pain, it's also an emotional experience, it's a social experience, it can be also, it's also a spiritual experience. So you have all these spheres, components of us as humans impacting on how we perceive and experience pain. So when we engage in these cognitive and behavioral strategies, we are not just focusing on the psychological aspects, but also looking at the entire holistic view of what's helpful in making us whole and pain-free. So for one of the broadest evidence base that we have for this strategy is the use of the cognitive behavioral therapy. So you'll note in that the picture there, I don't know whether it's going to be for me, it's to my right top corner. Most of the thoughts we have, we just feel they're also meshed up in our head. We don't have clarity of what's going on. And with CBT, we're trying to get to the root cause of what is it that we think, and how does that influence what we do and how we respond. So getting to the core beliefs that we may hold and really trying to challenge them on whether they really hold any truth to them, so that when we respond from a place of facts other than a place of intuition or just a belief that may not be founded. So CBT really is one of the modalities that has the biggest evidence. In my clinic, we have a social worker, Harpreet, who is really the expert with delivering these modalities for patients as she works with them to promote their mental wellness. It's great to know. Yesterday, when we did the spatial forum with the other hospitals, it was great to hear most hospitals now have incorporated a social worker who is able to offer clinical counseling for most of these strategies. And we hope this can only continue to grow so that our patients will be able to access this. The other strategies that research mentions as also proved as beneficial would be things like acceptance and commitment therapy, the PAAC, mindfulness-based treatments, guided imagery, meditation. things like deep breathing. Sorry, I went a little too fast. Doing affirmations in the morning prayer. And something that's now gaining quite a bit of attention is virtual reality. So virtual reality is a chance to immerse into another whole world altogether that's maybe calmer and that can allow healing to happen. So I was thinking about the kids. They're always going for these birthday parties invited by a friend to some virtual reality studio. And you get your headset, your goggles, and then all of a sudden, I'm not in my boring backyard or room. I'm out in a place like this nice, beautiful mountain area, hearing the birds chirping, the rivers flowing, and some of them are even being supported by some guided imagery where you can have the benefit of all these other modalities here we were mentioning as you go through that virtual reality. So Harvard University has a collaboration with one of its partner hospitals, Spalding Hospital, and this is becoming quite an area of interesting research where they are actually coming up with one specific for low back pain management. And so far, it has been very promising, and studies are ongoing. Possibly when it becomes more evidence comes through, it may become a standard of treatment for really anybody with these chronic pains. And I think there was a talk on virtual reality, which possibly was able to dig more into that. But that's an interesting area of intervention that's coming up and very promising. So I'm almost over with my time, but before we transition over to Lance to hear more of his lived experience, I will welcome us just to take 1 minute. All right, you can choose to maybe pause your video, whichever works for you, or just sit where you are and maybe close your eyes. And let's just have 1 minute of mindfulness to situate ourselves better as we go through this, because some of this information may be triggering for us, maybe living with different types of challenges. And this will just help us to anchor and ground us more before we transition to our next part. So come with me.
Enjoy this mindfulness exercise. Take a seat with your feet on the ground. Take a deep breath in. Feel your body as you inhale. Take a long breath out. Notice your body as you exhale. Follow your breath in and out. Rest your mind on your belly or your chest or at your nostrils. Just be aware as you breathe in and aware as you breathe out. This concludes the mindfulness.
Thank you. I'll take it over to Amos or to Lance.
Thank you, Ms. Kahenya, for your great presentation. And if Lance can start sharing his slides, that'd be great.
Thank you, Amos. Thank you, Beatrice. And hello, everyone. I will be presenting today on my lived experience. Ultimately, I plan to introduce my main strategies. But first, I want to provide you with a rationale for why these non-pharmacological interventions are a part of my repertoire for coping with sickle cell pain. So we know that sickle cell pain can be multifocal, multifactorial. Multifocal in the sense that it addresses or it attacks many different parts of our bodies. For me specifically, my shoulders, chest, back, abdomen, hips, and even gums. I know that the different triggers could be related to extreme temperatures, rainy weather, dehydration, and even emotional stress. For this reason, relying on one method to manage the pain is insufficient for me. And so I find that supplementing the pharmacological intervention with non-pharmacological interventions, it helps me to bounce back quicker, experience greater quality of life, and it even decreases the exposure to adverse side effects of the medication. But my decision to choose non-medicinal treatment approaches depend on the location of the pain. So whether it's in my abdomen versus my shoulder, it depends on pain type. For example, is it acute, chronic, or neuropathic? And it also depends on the severity. We are encouraged to rate our pains from 1 to 10. These are the factors that I consider when selecting the different interventions I will be introducing to you shortly. I found, though, that for me, I can classify my most helpful interventions into 3 domains. The relaxation strategies is one domain, cognitive strategies is another, and distraction strategies is a third. Beatrice spoke about the CBT, which would fall under the cognitive strategies for me, which I will explain a little bit in detail. But first, I'd like to start with why I choose relaxation strategies. We know that sickle cell pain is a stressor, both physically and psychologically. And emotional stress in particular has a way of activating the sympathetic nervous system. This is the body's way of responding to threats and stressors in general. And this is where we get the idea of the fight or the flight or even the freeze phenomenon. And in my experience, pain has a way of activating this system as well. So I find that my heart rate increases whenever I'm in pain. I find that my breathing becomes more shallow and even rapid, and I have muscle tension as well. So whenever these experiences are happening, they suggest to me that the sympathetic nervous system is being activated. Therefore, using relaxation strategies would activate the parasympathetic nervous system, which is the body's way of recovering from stressors. Relaxation strategies, they have a really good way of getting us to calm down, basically. They decrease our heart rate, they normalize respiratory rate, blood pressure, and even correct the pupil being dilated. So what are some of these relaxation strategies I turn to? I turn to deep breathing. And sometimes I find myself simply imagining a dot of my favorite color on the wall in front of me. And as I breathe in, the dot expands. And as I breathe out, it shrinks. Doing this repeatedly helps me regain control over my breath. It helps me to have a more steady pace, recognizing that if I'm ever going to recover from the perceived threat, it's important that my breathing is a little bit more regulated, controlled. But there are times when pain is so severe that it is hard for me to independently engage in deep breathing. And so I turn my attention to an app called Insight Timer. Insight Timer is available in Google Play Store, Android, and all, well, that's with Google, right? But iPhone, and Play Store as well. And this app it offers breath work, it offers mindfulness exercises, bedtime stories, guided visualizations, and soothing music tracks. When I turn to this app, what I get from the experience is I'm more inclined to experience greater relief in a faster time than if I were to just be doing breath work independently, where I'm imagining this dot, or if I'm making sure that I'm counting to 5 and holding my breath for 4 seconds and then releasing for 6 seconds. The app does a really good job at just guiding me through whatever is necessary to help bring about relaxation. I actually used it last night and I was so surprised at how quickly I was able to fall asleep. And then it goes on to include praying and Bible reading. Because I'm highly spiritual, there is this sense of groundedness that comes with praying and reading my Bible. It increases a sense of connection to God, and it reminds me of his closeness and his power. So that's it for the relaxation strategies. Now we talk about the cognitive strategies, recognizing that when we are aware of our thoughts, it enables us to evaluate them in terms of their rationality and their helpfulness. Pain catastrophizing is a major part of how I experience sickle cell pain. Pain catastrophizing simply is me making a mountain out of a molehill, let's say that, or even just thinking worst case scenario. And I give you the example, I've been having shoulder pain for 10 to 12 days recently. And my mind was telling me that this is AVN, you're gonna have to do surgery. You're gonna have to start physiotherapy again. You're gonna need this, you're gonna need that. And because of this pain experience over a period of a week and a half, I found myself going to worst case scenarios. So using cognitive strategies helps to challenge negative thoughts that would contribute to stress, contribute to my depressive state, and even contribute to anxious arousal. I will explain this a little bit more in this slide. So challenging my thoughts require cognitive reframing. Beatrice talked much about CBT earlier, and this is a component of cognitive behavioral therapy where we are literally looking at the evidence to support some of these thoughts that we might have. In my experience, whenever I'm having pain, the common themes seem to be helplessness, lack of control over outcomes, sense of worthlessness, and inadequacy. And so because the pain triggers these interesting ways of thinking, I challenge it by going to these 4 self-help realistic statements that I found most helpful over the years. And the first one is, not because I think it doesn't make it true. Going back to the experience of my shoulder pain, here I am thinking that this is avascular necrosis all over again. This is going to require surgery, not because I think it does not make it true. Especially because it's not being supported by an X-ray, or the pain has not been so severe that I'm not able to lift my limb or my shoulder anymore. Yeah, there's just no evidence for it. So that is my top realistic self-talk statement. My second one is, this difficult and painful experience will soon be over. I've had several crises before, and they have all been resolved. Maybe not as quickly as I'd like, but my experience is that it will pass eventually. So using that statement enables me to be a little bit more at peace with the experience, and it corrects this tendency to catastrophize, to make a big deal out of what's going on in that moment. I also turn to the statement that says, look at how much I've accomplished and I'm still progressing. I find that within us with sickle cell disease, we are all quite resilient folks. And even though the timelines might not be what we would have expected in terms of accomplishing certain goals, we continue to progress. And enabling this thought to take over in my moments where I'm having pain can also facilitate a sense of relaxation and peace for me. And then thirdly, or the fourth one, to correct the thought that I'm helpless, that I'm inadequate, and things are not working out for me, I turn to this one. I am not helpless. I can and will take steps needed to get through this crisis. This feeds well into problem solving in that if I'm thinking that I can and I will take the steps necessary to get through this crisis, I start to think of solutions. And these solutions are geared towards reducing my stress levels. So for example, in the capacity of a student, asking for extension is a really great stress reliever when I'm having a crisis. Asking my supervisor for time off or whether I could come in later is also a good way of reducing my stress level, because my pain is making me think that, you know, this is going to be an awful day. You're not going to be able to get through the day. You're helpless. You won't be able to handle things. But by problem solving, I find that, okay, I can breathe again. I have this extension. I have a supportive employer. And so I'm just going to tap into that so that I'm not overly stressed about this pain episode. Journaling is also another activity that I turn to because it gives me an opportunity to release my frustrations, my anger, my sadness that are also likely to be fueled by pain. And then the third category is distraction strategies. Beatrice talked about immersing ourselves in certain activities because this has a way of shifting our attention away from the pain sensation, especially when we shift our attention to more pleasurable activities. It works wonderfully in my experience, because I know that the more focused I am on the pain, the more distressed I become. So my distraction strategies include watching TV shows. I love to binge watch TV shows. And I know that I'm immersing myself because I find that I'm rewinding a particular scene that was really impactful. And that's just me being fully engaged in this TV show, in this movie scene. And when I'm doing that, I'm not necessarily thinking about my pain. So I've used this a lot when I've been hospitalized as well. I know that there are many views about sicklers being in pain and using their cell phone and thinking that it's not indicative of severe pain. But in my experience, I find that being on my cell phone while I'm waiting to be served or waiting to be assisted is really helpful in taking my mind away from the pain. I love French fries. And so anything to create a sense of pleasure in light of the pain can be really helpful in reducing the emotional stress that comes with muscle tension and increased heart rate. So my friends typically visit me in the hospital with French fries because they know that that's likely going to keep me going. And it helps to just release the muscle tension and all those factors contributing to pain. And even just being on the phone and talking to supportive people in my life, including my partner, my family members, and close friends, help to regain some peace and relaxation. And that's it for me.
Okay, great. Thank you for that great presentation, Lance. So I would like to open up questions to any of the participants. So you can ask questions using the chat feature or the Q&A. But just to get us started off, I'd like to ask our panelists a few questions. So I will start with Ms. Beatrice Kahenya. So the first question I have is, the fear that many patients may have is being misunderstood by doctors or nurses as not having real pain and trying to tame down the physical cues of pain by using some of these relaxation and distraction skills. Well, what would you say to that?
Yeah, that's a very good question. And I want to begin by acknowledging what Lance just mentioned. He's on his phone or whatever else he has to do to just get through a bad crisis, especially when in the hospital. And I can confidently tell you, when I initially began in my role with the inpatients, so these are patients who have been admitted with sickle cell pain episodes, for the most part severe. One of the concerns my colleagues had who are helping with managing these pains can be very complex, where how do we also objectively measure this pain? All right. We do find, because remember, as healthcare providers have been trained that there's a subjective reporting of the pain by the patient. This is also what you observe. You observe the physical cues, all right? You see people tightening their face, grimacing, wriggling, being restless, and all that physical, or all that you might physically see for pain. But it happened that for our sickle cell patients, we weren't seeing much of that physical cue, because most of them would be on the computer, watching a favorite show or something, and people are kind of like, is it really what's happening here? And to be honest with you, it's a moment of, sessions like these are good for us to bring this awareness that it's a way of coping. It's not what we have been trained to interpret, because pain is very subjective. We don't even have an imaging. I can't do an MRI and then ascertain, oh yes, you have a knee pain because the MRI said you have an AVN happening there. The MRI may not show, but if you do tell me that you're having pain there, I have to go by you, because pain is a very unique subjective experience. How people express it can be very diverse. We also have these patients who can also be very expressive physically on how they feel, all right? You go to the labor and delivery. These are women who have never really experienced pain. And I know from experience, they will be elaborate how they physically express that. But within this sickle cell realm, I can tell you I've witnessed that many of our patients have learned how to, to take on these distractions, these relaxation modalities to help them take that edge off. So really, it's a challenge for us as health clinicians to continue being aware through such forums. I do a lot of education to our emerge nurses, tell them the same thing. No, don't go by what you see, go by what they tell you, because this is real pain. So I will also encourage the patients to let that be known to the clinician. I actually tell to them proactively. Like, I do have patients who tell me, okay, you see me relaxed, I'm watching my computer, but I'm really in pain, just so you know. It's okay to communicate, because that way, that way they will be more aware that even though you present as relaxed and as okay, really that's not how you feel. So I do encourage our patients to also be expressive to proactively say that.
Thank you for that. So I have a question for Lance in the Q&A. So Sickle Cell News is asking, how can prayer and affirmation actually help with pain relief and management? And he's asking if there are any objective studies on this.
Yes. First, to answer the first part of the question, spirituality, religiosity has been shown in the literature to be effective in managing pain. It is reported that religiosity, spirituality, it increases that sense of purpose. We tend to get meaning from life, meaning for experiences by connecting to a higher power. And so using prayer to regain that sense of connection to a higher power gives a sense of meaning and purpose to our lives. And that's what the literature has shown. I remember seeing an article, because I presented on this last year as well, on the use of prayer and religion to support in managing sickle cell pain specifically. I can't remember the name of the author right now, but yeah, I've seen it in the literature.
Thank you for that. So there's another question for Lance. So this is from Natalie. She says, I would really appreciate to talk to Lance. Is it possible to get his contact information, or could you give him my contact information? So I work at a pain clinic at Ottawa Hospital, and I have an idea for a project that I would love to talk to him about. Please, thank you kindly.
That sounds good. I'm actually putting my contact information in the chat.
Awesome. And there's also a question, I think this could go to either of you. What other apps can you recommend for relaxation, hypnosis, or biofeedback?
Lance did mention Insight Time. I actually love that app. It's free. If you want to get into the premium version, you can do an annual fee, but I actually use the free version. It's very comprehensive. It gives you 5-minute options, 10 minutes, and I find it really, really good. There are others like Headspace, there's Calm. There are many now in YouTube, Spotify, all these places you can access either subscriptions or just free service.
Yeah.
Type some of those in the chat.
Another one that I've used in the past is Calm. I'm actually looking for it now, but I'm not seeing it in my apps. But Calm has been effective as well in just producing that sense of relaxation. In terms of biofeedback, hypnosis, I'm not familiar with the apps that are specific to those experiences, but I do know for sure that Insight Timer works wonders.
Mm-hmm.
Okay, thank you for that. So I have another question for Lance. So if someone tries to use some of these strategies that you suggested, but they don't seem to work, is there anything you can suggest that would be helpful?
Yeah, I think these strategies, they are skills. They work effectively when we have refined skills. So it requires much practicing. Even when we're not in pain, I would suggest that we try to practice using these skills so that they become second nature when we are experiencing a crisis. I know that for many, it's different. So it's just finding the ones that you think might be a good fit at the right time. Even as I mentioned, the idea that, it depends on the severity, it depends on the location of the pain, and it even depends on the type of pain. So if I'm having chest pain or even pain in my abdomen, deep breathing tends to work greatly. But if the pain is really deep and feels like avascular necrosis and it's chronic, I find that really immersing myself in things that are pleasurable for me are more likely to be effective in that moment.
I just want to add that we have to remember this is part of a comprehensive pain management plan that we should employ these modalities. If using any of this that we do mention is sufficient enough, then that should be okay. But if you do find you need more, then your clinicians should support you in putting in those other modalities we did mention. In some cases, you still might need some medications as needed. You might need the support of someone, a clinical counselor, so that they can guide you through this. So in my clinic, we do refer them to a chronic pain clinic. These are very comprehensive. They do, put in a very comprehensive approach to chronic pain management, where I did have one patient recently where you even have a pharmacist checking on you almost every day. You do have physio sessions on site. You do also have the doctors, the NPs prescribing treatments. So do use this, but also remember it's part of another comprehensive plan that you should access if need be.
Okay, great answer. So as we're coming to the end of this session, I will just open the poll for feedback on the session. If you have any other questions, if you could just say them now before we end, that'd be great. So, yep, the poll should be on your screen now. So if there are no other questions, I'd like to thank everyone for attending the session. I'd like to thank the speakers, Ms. Beatrice Kahenya and Mr. Lance Archer, for your great presentations. And thank you everyone for attending this session. And I'd like to invite you to the next sessions, which will be starting at 12:40. So if you could join via the Zoom link or via Feedloop, that'd be great. And if you could just quickly complete the poll that should be on your screen within the next 5 minutes or so, that'd be great. Thank you.